The impact of big data analysis in medicine, I think, is going to be as big or bigger than it's been in many other disciplines. I think it'll span the whole of biomedical science if we can get it to work. We've been very interested in accumulating very large data sets of a variety of kinds in medical science. And as the data sets accumulated, we became really clear that we were going to have to analyze these in some novel way. So we've been interested in bringing together groups of people who've been thinking about analyzing large data sets from a variety of different places to try and see whether we can bring together the existing expertise to both understand what's doable now, but also to plot out the future as to where big data analysis in medicine is likely to go. We thought very long and hard about what we would put into this meeting, because you could, in theory, put lots of different things, because big data will apply to lots of things in medical science. But the things where the need for analysis has been most pressing have been in the interface between epidemiology and genetics and genomics, which are sort of hooked up to each other, and disease surveillance. So we thought those would be the big three themes. And of course, we needed to have a session on the analytics, because the ability to make this work will depend highly on the way you analyze these large data sets. So those were the four major areas that we thought about. I think Richard doesn't need much introduction. He didn't really invent big data in healthcare, but he did invent big numbers in healthcare, which is pretty much the same thing, and he did it a long time before people started talking about big data. So it's a real pleasure to have him here today. Richard, over to you.
Because my idea of big numbers and the big numbers of today are just different. I used to talk in millions of people and billions of data points, and now it's all trillions.
It was wholly appropriate, I think, that we started this meeting with a talk by Richard Peto on large-scale epidemiology. This is an arena where big data has been around for a while. Richard has done some of the biggest epidemiological studies around the planet, and they've had a huge impact on our understanding of the major causes of premature death. And he gave a brilliant talk describing how he put together these studies and how they've generated data that really gives us an idea of the burden of disease and what are the things that are killing people on a global basis. So that's about as big as you can get in terms of data.
Richard Peto's talk was a tour de force of the value of very large and very well-designed epidemiological studies to help us learn about some of the risk factors in modern society. One example was smoking and our understanding over time of the damage to health caused by smoking, and the real changes you see in death rates in countries where smoking has decreased substantially, and the effects on people's lives, and many other examples where careful epidemiology on very large scales allows us to tease apart some of the important causes of death in order to know which ones we can avoid to improve longevity and human health.
It's an absolute disaster. They've already got 1 million deaths a year from smoking. It's going to be 2 million a year by 2030. It's going to be 3 million a year by the 2050. And worldwide, we've got something like 30 million new smokers every year. More than 20 million of those are going to keep smoking. If they keep smoking, more than about half of them are going to get killed by it. So we're going to finish up with more than 10 million tobacco deaths a year if we just keep on as we are now.
We also heard, for example, in Russia, where actually access to reliable statistics is difficult, but by careful study there, it was possible to see really extraordinary and extraordinarily rapid changes in particular non-cancer causes of death associated with alcohol consumption.
We did a study of this. We asked, if you want to know what a Russian man drinks, then ask his wife after he's dead. So we did. We asked them, we went and knocked on the door, please can you tell me what dead Fred used to drink? Oh yeah, he used to drink a bottle of vodka a day. And we could relate what they died from, the disease they died from, to how much they drank. So we compared those who were drinking a bottle a day versus the controls. And the controls, we couldn't have non-drinking controls because there weren't any.
When you're aware of those very important exposures that are causing premature death, then governments have an opportunity to do something. And China is, as aggressively as they possibly can, given that they have a big domestic tobacco industry, they're really trying to get on top of the smoking problem to prevent the crisis that Richard has described. Yeah, similarly, in Russia, there's been a huge effort to try and cap the amount of alcohol, excessive alcohol consumption, and try and control that in some kind of way to reduce the premature death in that setting. So it's a really good example of how our understanding of risk factors for premature death can lead to government intervention.
I quite like this. Atlas, believe me, carrying the world was much easier. I tried to think of a mythical Scottish character. I couldn't come up with one apart from Fraser. Do you remember that? We're all doomed. So, because I think there is a serious point here about what are the challenges of health systems, because if we're going to impact upon them, we need to align the value that we can deliver. And that's what we're trying to do in Scotland. This is a new slide, which links, excellence in life sciences, which is a theme of the next 2 days, through the common pathway of translation, clinical trials and innovation through to world-class patient care. And my argument is that biomedical informatics can accelerate that pathway.
Andrew Morris gave a great talk on how you can use electronic patient health records to drive better clinical care, but also to drive a research program. He's been working on this problem for a long time. Scotland has a pretty advanced electronic patient record system, but interestingly, in Scotland, probably the only therapeutic area domain where they've really made use of it has been diabetes, and that's been really attributable to Andrew Morris's work. His description about how that's led to dramatic improvements in the health of diabetics is a striking example of how you get quite big health gains, and at the same time you provide a really unique resource for research purposes.
So this is our amputation rate, down about 40%, sight-threatening retinopathy down by 43%. And I'm hopeful, because we've now got a national programme in, that in my lifetime we will have a year in Scotland where no one goes blind from diabetes. I think that's achievable through this systematic approach.
It's easy to forget how important the infectious diseases are in terms of premature death and mortality globally, particularly living in a secure Western environment. But the reality is we still have some very major killers that are infectious diseases globally. Malaria, dengue fever, tuberculosis, the major diarrheal diseases, these are all really serious threats. In addition, one of the great public health threats, I think, to us in the West, as well as to people elsewhere, is the acquisition of transmissibility, in other words, the tendency for viruses to be transmitted easily, of a major respiratory pathogen that carries a high mortality. It's easy to forget that the avian flu, H5N1 flu, carries a mortality of 50%, and the only thing that's prevented it from killing 50% of the world's population is the fact that it's not very transmissible. So if you think about that, you realize that infectious disease is an area where you have to start to apply these modern tools if we're going to get on top of these public health issues.
More insights into that a bit later. But this is an urgent global attempt to try and define this problem, characterize it, and then contain it. And we desperately need a...
Nick White's talk was, I think, extremely informative in that he uncovered, I think, a problem that a lot of us had not really thought about, and that is, it's one thing measuring the number of malaria cases, but if you don't even have local infrastructure to provide the labs you need to do the diagnostics, then you can't really be sure who's got malaria and who doesn't have malaria. And so ascertaining appropriate populations in a robust way so you have the data on the numbers of cases of malaria is extremely difficult. And if you're trying to do that on a global basis, Southeast Asia, Africa and the likes, your numbers get very wobbly very, very quickly.
So this is the go-to information of infectious diseases in the world. And if you don't believe me, if you just look up all the studies that look at pathogen biodiversity, risk for emerging infectious diseases, they all use this database. And if you just ping on a disease that you might know a little bit about, it's just terrible. If you look at the malaria one, it's just a fiction. And
surprisingly, our ability to map even relatively simple infectious diseases to define their prevalence and transmissibility on a global basis is actually pretty poor. Simon Hay gave a talk which really described the problems in doing this even for common ordinary pathogens, and it turns out that in fact we have no rigorous and accurate mapping data for any infectious disease?
I've been working in infectious disease surveillance for approximately 20 years now. I think this conference was great in highlighting the fact that through many different avenues, and particularly for us in relation to social media, we're moving into a time where the data itself will not be restrictive on epidemiological insight. It will be our ability to process much of the large information data sets that are coming in through things like social media. And it's those challenges that this conference really highlighted and that we'll be able to capitalise on, I hope, in the very near future.
One of the major health challenges we face is how to cope with pathogens, bacteria and other pathogens, developing resistance to the drugs we use. Antibiotics for bacterial pathogens, antimalarials for malaria and so on. And there are a number of talks at the conference which gave us real insights into some of the factors involved in the regions where those resistance genes develop and the way in which they can spread.
You may have heard, for example, of the NDM metallobeta-lactamase that can be cultured readily from puddles in Delhi, which is resistant to pretty much all antibiotics, and is global and is spread now by it's called aeroplanes, and we can now recover these infections throughout the world. If we look at the antibacterials, this was the golden period, and although there are a few down here, that's a skin cream, that's a skin cream. These two are very difficult parenteral antibiotics. That's the only real, the unpronounceable one here, which it will be linezolid for those of you who are physicians. That's the only really new class of antibiotics we've discovered since the 1970s.
There was a particular example in that session about the spread of drug-resistant malaria parasites and about how it had been mapped to one particular area in Cambodia.
Artemisinin is the mainstay of global malaria control. If this spreads globally, you can forget about all the optimism and the gains in mortality and morbidity. It's going to blow apart global malaria control. We'd be right back to the beginning. So this is a global health emergency.
Now, it was sobering in terms of the consequences for us if we're not able to tackle that problem well. It provided a little bit of hope in terms of us understanding the issues better and perhaps being able to work harder to narrow down the areas we have to be careful about and the areas where we have to try and quarantine and eliminate resistance genes.
Genomics has undoubtedly been a major driver for people to think about big data. And the reason is you can generate big data now with the technologies associated with genomics. And one of the things that I think was highlighted by all the speakers is the speed at which this revolution is occurring and the extent and depth of the information that you can generate about the underpinning genetic basis of disease and the genetic variation between human populations. That is going to lead to a huge opportunity for major medical advances, but it'll only come if you can analyze the data in some sensible way.
Even the most optimistic views of genomics that were articulated in this strategic plan in 2003, I don't think any of us could have anticipated things were going to happen as fast and as effective as they had.
Eric Green is a perfect person to talk about both the past and the future of genomics. But what he described was a bold vision about how this is likely to play out in the clinic. And he described, I think, quite accurately how quickly this is likely to be taken up in real clinical practice. And of course, the recent announcement of the Department of Health in the UK to sequence 100,000 genomes is a perfect example of how that's being applied now in real patients.
What I found particularly interesting from the conference was this kind of big data sandwich. There's big data coming from two directions, from the large cohorts and phenotyping observational studies that are being set up, and there's big data coming from the molecular level, from the genetics and from the genomics.
So we can begin to now answer these questions. What are accurate models for describing human genetic diversity? How do we use these kinds of data to reconstruct recent personal genetic history, going to sort of a tools common theme? How do we use the many to learn about the one? And why might this be relevant to the design of future medical genetic studies?
One of the aspects I found most interesting about the conference is where these worlds are starting to meet. And of course, this is, I think, one of the great promises of big data.
really helpful to have a session which focused on computing and analytics, because those in many ways will be some of the limiting factors in making this big data analysis in the healthcare system work properly.
Here's what I worry about. I worry about this fifth step. I worry about our ability to actually analyze this data. This is a pervasive problem that's going to affect all these. I mean, it's probably the main topic of this conference, big data. How are we going to deal with it? And there's many aspects of this bottleneck, and it really is.
One of the most important things of meetings like this is it brings people from different disciplines together. So I've got a view that innovation at its best always comes from different disciplines talking to each other. And this is a classic example about how big data is going to produce some very innovative outputs. And it'll come from the interface of people who are in classical medical research coming into contact with people who think like computing scientists or like engineers. The whole concept of machine learning, I think, is a really good example of that, of how you can take large data sets and you can use computational methodology to actually generate intelligent outputs about what relates to what and what is predictive in those settings. Una May O'Reilly, for example, gave some beautiful examples of how you could use evolutionary algorithms to take data which was obtained by patients and develop that data in a way that it could be much more predictive in terms of what was going to happen to patients and what wasn't.
So as EC Star is evolving and searching for models for you with your data, you can sit external to it and tap it and say, give me what you got that's best right now.
And that's a good example of how computing science technology can be used in really novel ways in a healthcare setting. There is no way that conventional biomedical scientists could have come up with that, but the interface with people with strong computing science or engineering backgrounds can really help.
I think it was Russ who said at some stage we want to have a database that's got kind of every person in the world on it and all sorts of rich phenotype information. And when I want to know, I'm a doctor and I've got someone who's got a mutation in this gene in this position, I want to know what the consequences of that are. What do? I look up the database and see all the other people who have got that and see whether there are phenotypic things they share in common. So I really, really do think on what is one of the biggest challenges we have in this space, that big data isn't just an opportunity, it's probably the answer. It's great in a forum like the one we had at the conference to be able to talk about the opportunities and the challenges in this kind of area, but what really matters is making sure that those discussions have positive and real outcomes going forward. One area in which I think they will, and probably already have, is in bringing together people from different parts of the field so that they could interact and get to know each other, and I'm sure it will be the case already that there are new collaborations in place forged by people meeting and understanding things at the conference.
There were people who would never otherwise have met who were in the same room. They had particular approaches to big data, and bringing them together, I think, will yield some fantastically effective collaborations. There were people from Oxford who'd never met, and I'm sure already collaborations are developing.
It was incredibly useful to have this conference at this particular time in Oxford. We really are at the cusp of a wave in terms of data generation, and so to be there with delegates, with with the experts that you can quiz on a one-to-one, and we start a conversation that might lead in many different directions and in directions which you wouldn't necessarily kind of think of a priori, was fantastically useful.
Stanford has really unique expertise in this field, particularly in the interfaces between medicine, computing science, medicine and engineering, where they've had a tremendously successful track record. Oxford's expertise is in different domains: epidemiology, genetics, genomics, large population cohorts. And so the two of them make out almost a perfect match. It would be hard not to say that I was incredibly excited by the output of this meeting. I always felt that the big data challenge was one which would create all kinds of opportunities for medical research and medical practice. But everything I heard during the course of those 2 days suggested that this was really going to be a defining moment for the whole field of medicine. We will, for the first time, be able to do studies at scale that will be able to understand what are sometimes relatively small but nevertheless important effects that you can only detect if you're looking at large patient populations. It'll tell us about who's got the disease, where they've got it, how do we do the disease surveillance in an effective way, what causes disease, what its natural history is, how we define disease. You can't think of a list which could redefine the whole field of medicine more effectively. So I'm very excited about where this is likely to lead us.